everyone. My name is Taylor Sullivan. I am studying occupational and environmental epidemiology at the University of Michigan. And today I will be talking about breast cancer epidemiology and treatment in Tanzania. Okay, so I'll go through the background of breast cancer as well as just healthcare in general in Tanzania and the goals of my study. Then I'll talk about finding records and entering records, which we've heard a bit about already. Then I'll talk about my results initially, which are pretty basic at the moment, and my plans. Then I will talk about the strengths and limitations of ORCI and maybe future research ideas. And finally, the lessons I learned while I was over there. So, okay, it's just slow. First, we'll go over some basic facts about breast cancer globally and in Tanzania. It's the top cancer in women worldwide, with 1.7 million new cases and about 500,000 deaths, and that statistic is from 2012. However, low and middle income countries account for half of those deaths and or half of those new cases, but 62% of deaths. So that means that even though there's an equal distribution of new cases, it seems like among low and middle income and high income countries, low and middle income countries account for 62% of deaths. Some risk factors for breast cancer include a long menstrual history, recent use of oral contraceptives, never having children, while breastfeeding and having children decrease the risk. And yeah. So next we can overview the healthcare system in Tanzania. So as some other people mentioned, we worked at the Ocean Road Cancer Institute, which is located in Dar es Salaam. You can see the star on the map there, which is on the coast of Tanzania. And this is important because there are 52 possible referring hospitals in the country, but it's a huge country. It's like 365,000 square miles, which in other words is like 4.7 Nebraskas in this one country. So if you live on the very far side, it's really hard to get to Dar es Salaam to get treatment if you need it. Because, like I said, ORCI is currently the only cancer treatment center in the country. So most of the people also live in rural areas, which means like it's really hard to get there. And then not a lot of hospitals are cancer screening centers. So that means that most people who do come to ORCI present at later stages of breast cancer. If they do get there, there are a range of services that people can have, such as chemotherapy, radiotherapy, imaging and diagnosis, as well as just palliative care. So breast cancer is the second most common cancer in Tanzanian women, but there are very few studies done on breast cancer, especially in Tanzania. So this is probably because the country and health system as a whole was preoccupied with infectious diseases such as HIV/AIDS and malaria, which makes a lot of sense. But as life expectancy is increasing, breast cancer is becoming more of a problem, and it's important to look at. So the last really comprehensive epidemiology study was done with data from 2007 to 2009. And so there is a need to update the literature, and my study was kind of trying to replicate that in some ways and expand on it. So what we know so far is that breast cancer is a really big problem worldwide, with high mortality rates in low and middle income countries. We know that cancer screening is relatively new in Tanzania, and treatment is hard to get, and there are not many studies on this yet, which leads to the goals of my study, which were to create a database of breast cancer patients from 2012 to 2016, and report epidemiological trends in those breast cancer patients, and then analyze the association between the clinical symptoms and presentation, the diagnostic measures, so like what you get done like chest x-ray or cytology, histopathology, and then the treatment trends from those. So we've kind of already talked about this a little bit, but my research methods really involve two big steps. So finding records and entering records. In order to find the record numbers for the breast cancer patients, I had to look through this logbook, which we've seen before, to write down the record numbers for cases, and then take those records numbers and go in the records room, pictured here, as we've seen before, and find those records from these stacks of records that may or may not be organized. So that was the plan, but expectations were pretty different from reality. So in reality, when I went to look for the 2013 logbook to find the 2013 cases, it was just gone completely. So no one in the records room knew where it was ever. So that means I couldn't include 2013. Additionally, I think Richard mentioned this earlier, but they just switched over to an electronic record system in 2016. So they had, in theory, a lot of records in this electronic database, but the way the physicians actually entered the records was not very thorough. They would say, like, looks bad or something for, like, the symptoms presentation. So it wasn't thorough enough for me to include in my study, and so 2016 is also not included. Additionally, half of the records that I was trying to find for 2012, 2014, and 2015, which were the remaining years, were missing. They were just not there. So I kind of combed through the records room a few times and then eventually enlisted the help of a few different assistants to help find them. And we did end up finding a good amount of them. I think, I don't have the exact number, but it's like about 70% of the records I was supposed to find, I did find, which is better than 50%. So the total number of records that I did find ended up being 753, and that was for 2012, 2014, and 2015. So once I found the records, this is what I did. I entered them. Yeah, I was really happy. Yeah, you're happy to have them, so it's good. Yeah, this was a retrospective study, obviously. I was going through the records and looking at kind of their medical information and their progress from diagnosis to treatment. I collected a lot of different variables on demographics, reproductive, clinical, diagnostic, and treatment information. There were 90 to 100 variables in my database in the end of it. Some of the information from previous hospitals were in the medical records as well. And Richard also kind of mentioned this, that it was hard to tell if people came to ORCI first and then to Muhimbili, or the other way around, but a lot of times the original medical record or other medical records would be in there as well. So that was helpful sometimes. However, a lot of the data within the medical record was very inconsistent. So sometimes there would be a lot of demographic information, like very detailed about, where they work, their education, and then sometimes it would just be nothing at all and it would just skip right to the treatment without giving like a background on the patient themselves. So that was also a challenge that I will cover later too. And then I had 2 more assistants to help me enter the data once I actually had the records, which was very exciting. So I've spent most of my summer entering the data, and so I haven't had time to properly analyze it yet, but I have some initial results and just kind of like summary of demographics here. And right now I've only completely entered the year 2015, so these results just reflect that year. I just want to make that clear. So there were 2 types of kind of insurance status that the hospital recorded. There was no insurance, and they went to one record room, and then the National Health Insurance Fund, and they went to a different records room. And so 22% of patients had insurance, 39% did not, and then 39% of the records were missing. And so insurance status, and like, this is kind of how I determined if the records were missing or not. Then, of the records that I did find, 94% were women, 4% were men, and 2% didn't record that. The age ranged from 22 to 88 years old, with a mean age of 50-ish and a median of 47. Of the women, 18% had a history of breastfeeding, and then 82% were no/missing. So this was one of the things that was often just not written down. Sometimes it was written down as, like no history of breastfeeding, but I didn't feel comfortable including that as like a separate statistic because missing could just be no history of breastfeeding too, the way they wrote the records. Of the women, 22% had contraceptive use, and 30% did not, and 48% did not have that information missing and written in the records. And then I also wanted to talk about receptor status because this is one of the variables that eventually I'm interested in analyzing. So estrogen and progesterone, or ER/PR receptors, are indicative of the type of breast cancer and also of possible treatments, so like hormonal therapies. And this is one of the variables that is kind of different in high-income versus low and middle-income countries in different parts of the world. And so just the basic analysis, the basic demographics of the receptor status was that about 50% of the estrogen receptors were negative and 65% of progesterone receptors were negative. What I need to do eventually is kind of, you're supposed to like group ER and PR together for the one patient, so it would be like ER negative, PR negative. But I just didn't have the time to do that before coming here, but I thought this initial glimpse was kind of interesting to look at. So, reminder, this is only from like these two portions. Like all of these statistics are just from these because 39% were missing. So that kind of leads me to my plans. First and foremost, I need to enter information completely for 2012 and 14. They're both partially done, but I want to get one complete year for this presentation. So obviously I have to include all of that. And then these are some of the questions I want to ask. So does insurance or lack thereof relate to what kind of diagnosis and treatment you get? Do diagnostic tests or lack thereof relate to what kind of treatment you get? Are there any emerging demographic trends over time? So this would be the demographic variables I was looking at. And then is there any relationship between receptor status and the type of treatment that people eventually get? So this has already kind of been talked about a little bit, but there were a few different strengths and limitations of working at Ocean Road Cancer Institute, or ORCI. So ORCI is a leading cancer institute in Tanzania, which is great because this allowed me to conduct a really large study on breast cancer in Tanzania that hasn't really been done before. On that note, ORCI is the only cancer institute in Tanzania, so this means that the study will be one of the very few epidemiological studies done on breast cancer in this country, which is sad but also exciting because that means new information is going to come out. However, there were a lot of limitations of ORCI, which have also kind of been talked about, but I think the biggest one was paper records. So this just kind of meant there was a lot of trouble reading the records, there were torn pages, there was smudged writing, and no uniform system, like I mentioned before, of actually writing down patient information in the record. It was just kind of like, it seemed like what the patient maybe told them. Some doctors were much better than others, but the records themselves weren't very uniform within the records. Missing data is probably my biggest limitation. So I wanted to do 2012 to 2016 at least, and I was just very limited to 2 to 3 years worth of data, and that means I can't really look at trends over a period of time, but I am excited to analyze within what I have. And then lastly, there was poor organization, so it was just really difficult to actually find the records that I needed and to communicate what I needed to the people who were trying to help me as well. And Stacy kind of talked about that a little bit. There were different record numbers for different patients in different offices. So a lot of people would come to the first office first and then move to the insurance office but get a different number that was only linked through a very obscure path that only some people could find. It was just very hard to actually find the records, and I was the one most of the time who was actually pulling the records, so that was just very difficult. And then I want to talk about some ideas for future students. So first and foremost, I think it's really important to clean up the records room, and I think that we were talking about this as we were working. There was some downtime because things do move pole, just really slow. So I think having a side project like that would not be a bad idea. It's so needed, and if anyone goes back here and tries to do the kind of research that we were doing, it would be so much easier if the records room was not falling apart, literally falling apart. And then I also think it would be worth it to transfer some of the logbooks at least and medical records to an electronic form. This is one of the logbooks, it's just falling apart, and that's just from 2014. So I got to look at some of the logbooks from 2009 and 2011, and you just can't read them anymore. So I think it would be beneficial for ORCI to have just an electronic copy of these. And I think that could be tied into a bigger project about record keeping and looking at, how the accuracy of medical records across years and between this new electronic system and the paper records, and just kind of, I think the administrative aspect is really important in healthcare and often is forgotten. But on the topic of breast cancer, I think that it's really important to continue the breast cancer research in Tanzania. Although I don't have really formal results yet, I think that it's important for future students to look at the screening practices especially and see if maybe those can explain any of my results, and especially the demographic trends and treatment trends, to see if there's any relationship between screening and how diagnosis and treatment works. So I could talk for a very long time about all the lessons that I learned over there, but I think first and foremost is patience. So I've explained my struggles with records a lot so far, and it just really took a lot of patience and taking things slowly and taking things one at a time. Knowing I would get my work done, I just had to kind of wait. I think it's also noted that it's important to appreciate and use all of your resources to solve problems. So, towards the end, I realized that I would not be able to enter all of the records in Tanzania, and so I found a way to scan the records while de-identifying them using my phone, and that's just a resource that I had that the hospital didn't necessarily have. When I asked them if they would have some sort of resource for scanning, they just kind of laughed and were like, we're not going to do that for you. Just using your resources, including people. So the records people did not like working with me necessarily, and I think it was maybe an issue of respect, and so a lot of times I had to go through the directors to ask them to do the work, and it would get done very quickly. And I think just knowing that there will always be challenges like that in different work environments, and I think it's important to know who you need to talk to get something done, instead of just kind of floundering and not being able to get the work done yourself. And then also it's important to be flexible and know when you have to adjust your original plan. So like I said, I am not able to analyze 2 years that I thought I would be able to, but it's important to know when to push and really try to get it done and find the missing records, or maybe it's time to just not include 2016. But yeah, that's really important. So after I finish my degree in the spring, I think I want to work in either government or in a nonprofit setting. I have a lot of experience working with nonprofits for the past 5 years, and so I would love to get back into that. And I think I would probably want to stay in my home state of Michigan. Eventually, I want to get my PhD in something related to cancer epidemiology. I'm really passionate about researching chronic diseases, especially cancer and stroke, and so I'm interested in these things, and I think that's what I want to study for the rest of my life eventually. So yeah, that's about it. These are the 4 of us who went. Are there any questions?
Great job and great summary of the challenges there. And I see you're relaxed now, but you were not relaxed there. But this is really interesting. And I'm still optimistic about the new system of electronic medical records. I know that you are not optimistic about it, but when we got Dr. Musilagi to talk to us, I think it's a very impressive system. And I think the main issue is who is authorized to get access to the electronic medical system and who is authorized to get the data and print the data. But I think this is the way forward to move from this mess into electronic medical system. So we'll see. It will be very interesting to look at the PR, ERPR, positive and negative. Did you find any HER2 results in?
Yeah, I have those too.
That would be interesting too.
Yeah, so I'll look at the 3 of those for hopefully like combine them for each patient. if that
And
makes
you
sense.
have multiple projects for multiple papers here, so
Yeah.
you want to focus mainly on what you're going to do because you have a lot. And I think one of the straightforward papers would be the receptor status and treatment. And that would be interesting, but you have a lot here to talk about. Questions, comments?
One of the questions I had is, one of the things that is risk factor is oral contraceptive use.
Mhm.
And I wasn't aware that that was,
Yeah, I just read
Yeah,
that from
short-term.
my literature review,
Yeah.
but like recent use of oral contraceptives.
Wow.
It was interesting because a lot of people use implants, like in Tanzania. When I was reading through the medical records, it would say
Yeah.
contraceptive like implant. And I'm not sure of like the difference in risk factors between oral contraceptives and implants or other types of contraceptives. So
I know one of the big things in the United States has been, the postmenopausal use of estrogens as related to breast cancer. And as that's decreased, that's really changed the incidence of breast cancer in that particular age group and stuff. But I wasn't aware of oral contraceptives, which is, I think, a big message to me.
yeah,
That
One of the assumptions that we have is, an electronic medical record is, an ideal solution for many, many problems. But if you don't have a reliable source of electricity, Ocean Road Cancer Institute is a lovely place, and they have many advantages, but they don't always have electricity. And when they built the new building, I noticed that there was this big generator out to the side. They said, "Oh, that's the backup generator." I said, "That's fabulous." He said, "But it doesn't work." And we don't have any diesel for it.
I think they're doing better now, right?
I think it's better. The power did go out like semi-frequently. So I think that is like a really interesting challenge, just like the use of computers and also training the doctors to use computers and to use it, like this specific system. I am optimistic about it, but I think it's just gonna take like a decade to like really, really get it down, which is totally fair. I think, we're still working on perfecting the system here, so yeah.
Your missing data is going to make it impossible to do a time series. But if you were to look cross-sectionally at the data you have a lot of risk factors. So you've got a lot to do there. Do you have other comparable, either East African or Sub-Saharan African studies that you can use as sort of guidance and also comparison?
Yeah, so yes, I know there have been studies in Kenya, but a lot of the studies I found are in kind of northern Africa and western, but I think that is going to be interesting to read more about. For what I was reading, I was trying to focus on just like Tanzania and like risk factors there and kind of screening practices, but I have like a list of articles in my like international folder on my computer that I have yet to read.
Related to this then, the missing data are missing, there's nothing you can do to get them back probably.
Right.
Any reason to think that those are a biased subset, and would that influence your analysis?
Possibly. So the biggest issue that I've thought about so far is that from 2015, I have more records missing, so I only have like 60%, than for 2014 and 2012. I have a much greater percent found for those years, and I think I'm pretty sure it's because that people are still getting treatment, so their physical record is with them somewhere. And so, yes, I think that is a potential issue. I do have information for where the patient was referred from, like how old they are, basic demographics for the missing data as well, from like the logbook. So I'm hoping to see if that information matches the ones that I found, and so maybe that can eliminate some sort of bias, but I have not done that yet.
And you're gonna compare those with missing records and patients
Yeah.
with no missing records to show.
So I have that information for both.
Yeah, great.
Joel?
Other questions, comments?
Yeah, would you say that, given the struggles that you mentioned with EMR and whatnot, you say that Tanzania has that healthcare is their priority?
Yeah, I think it's just like chronic diseases and cancer that is harder to justify in a lot of ways, and I think that makes sense, right? If you're in a really limited resource setting, then we would walk through the hospital and people would ask us if we're doctors or nurses, like, can you help us right now? And so I think the value of like long-term studies and epidemiology and really like developing the infrastructure for like records, like that is definitely not like a priority when you have people dying in your hospital, like outside of your hospital. So it's hard to justify, and I understand it. And I think like ideally, I was talking to some people in finance about this, that like you should do like a cost benefit analysis of how beneficial this would be. And I can't do that, but I think that would also be a really cool project for like future students, and maybe not in epidemiology, but I think it's definitely worth it to like kind of like show the government that like chronic diseases are coming and they're really important, and if you have the infrastructure in place, it'll be like so much easier and more efficient to manage. So, yeah, talking this for a long time, but.
One of the previous experiences that we had in the CEESP program is to send the students again to the same country. We cannot fund the student from the grant, but when we had funding from other sources in Michigan, we send students again. And you have experience about the records, about Turkahesa and how to work the system. So if you are interested in going back to the country, let us know. Or if you want to go to the same country or another country, I think this will be an experience that will be beneficial for you and for us too.
Do you have a question?
Oh, I did, and I'm sorry if I missed it. Did you, I was curious what screening practices were employed in Tanzania. I wasn't sure if they do clinical breast exams, if they're just relying on women doing self-breast breast exams, or if there's mammography.
Yeah, so I didn't really focus on screening a lot, but I know they do have a screening clinic within the hospital, so that is one of the services. And then I know it's like surrounding kind of the smaller like regional hospitals and kind of like the first place you go. I know there is screening efforts there. There are screening efforts there, but I was not focusing, so I don't know. But they do mammograms, and like I have a whole list of like diagnostic kind of procedures, but one of the issues is like if you can afford that or not. So like only 20%-ish had insurance. So yeah, it'll be interesting to look at, I'm sure. Joel.
As a follow-up to my question and add on to that, so my project was working on a mobile unit for patients who don't have insurance.
Yeah.
And providing them access to mammograms. Does Tanzania, like, do you think that'd be possible for Tanzania to support that kind of program?
Yeah, I do think so. And we talked to Dr. Musalek, the director of the Cancer Institute, a little bit about that. I know he's been really influential in implementing lots of like screening clinics. I don't know if they're mobile. I think there was talk of like a mobile mammogram service, but yeah, no, he was definitely talking about that, and I know he's been working on that recently, so it's happening.
It just started at ORCI, the breast cancer screening program, and it will be interesting to evaluate this program. From an epidemiologic standpoint, it's not the best use of their resources to go with population-based screening, because still the incidence of breast cancer in this country is significantly lower like a place like the US. Cervical cancer, you go population-based because it's high. But for breast cancer, you're gonna screen, if you're gonna go population-based, you're gonna screen so many women, and you're gonna identify a limited number of cases. So from an economic standpoint, it's not the best cost-effective project, but it could be for high-risk population. Thank you, Taylor.